So in this video, we're going to go over dopamine, its mechanism of action, its application to cardiogenic shock, its risks, its benefits, and why we actually have it. Because dopamine is quite beneficial for its use that we have it for in the pre-hospital setting in Ontario, because it's akin to basically switching vasopressors when we have this capability of titrating the dose to exert other physiological effects. So depending on the dose, it can do different things, which is quite important because we can give it for cardiogenic shock patients, we can give it for ROS patients, we can give it for patients with experiencing bradycardia and hemodynamic instability. So that's why we have it, right? And we'll compare and contrast to other vasopressors as well and reasons why we have it. So overall, dopamine can exert its physiological effects by binding to adrenergic receptors. So these are involved in the alpha-1 receptors. So we know those are abundantly found in all smooth muscle glands as well as organs. So when those are stimulated by dopamine, this leads to vasoconstriction. So this is why dopamine is considered a vasopressor. So basically, you're like squeezing or pressing down the blood vessels to push out more blood and constrict everything so all the blood gets kind of migrated to the core to perfuse their vital organs, right? That's why we have it. And again, alpha-1 receptors are found in the bladder because this will stimulate urinary retention. We don't want to excrete excessive amount of fluid, especially if we have insufficient blood flow. Because why would we want to lose more fluid when we're already compromised? Also, it leads to mydriasis. So this is the dilation of our pupil because obviously the third cranial nerve, the oculomotor nerve, is involved in pupil dilation and constriction. So alpha-1 receptors are present there, and this can lead to mydriasis or pupil dilation, in contrast to meiosis, which is involved in pupil constriction, which can happen in certain pathologies such as head injuries, as well as opiate overdoses, of course. And beta receptors, and specifically beta-1 receptors, are found in the heart and the kidneys. So obviously when these are stimulated, this can increase heart rate and contractility in the heart, because this would be very beneficial if patients are experiencing bradycardia and they have hypoperfusion because of this and hemodynamic instability, and this can increase the cardiac output and perfusion by increasing the heart rate depending on the dose, as well as there's beta-1 receptors in the kidney, which we'll talk about. So as you can see, the beta-1 receptors are present in the SA node and the AB node. So when these are stimulated, this can also increase inotropy, which is increased contraction, as well as chronotropy, which increases our heart rate, which subsequently leads to a rise in our cardiac output. Then the beta-1 receptors are involved in the renin-angiotensin-aldosterone system, so we won't go over an exhaustive review of this, but basically when these are stimulated, this leads to angiotensin II being released, which is a potent vasoconstrictor, and it leads to the reabsorption of water and sodium, which overall leads to fluid retention, because again, we want to conserve this fluid instead of excreting it, which would compromise our already kind of hypoperfusion state. As well, aldosterone is released, which again helps reabsorb sodium as well as water, and ADH is eventually released, which can be a potent vasoconstrictor and reabsorbs water and sodium as well. So that would be beneficial in improving hypoperfusion. So if you look kind of more microscopically, how does dopamine work and exert this increased contractility and heart rate? So dopamine binds to beta-1 receptors, and this is considered a G-coupled protein or G-protein coupled receptor. Think of these receptors as like parking spaces. And this is basically the regulatory mechanism from outside the cell to inside the cell, because we don't want everything coming in, because we have to regulate this objectively and efficiently, right? So when this is stimulated by dopamine, specifically the beta-1 receptor, this leads to adenosine cyclase, which is an enzyme. And we know enzymes are involved in chemical processes and speeding everything up. So the enzyme, adenosine cyclase, takes ATP, which are energy molecules, and converts it to cyclic AMP, which is a secondary messenger. So it helps communicate and establish roles inside the cell, but we need to exert a physiological effect. And overall, this leads to a rise of calcium in our cell, which subsequently leads to increased contractility and improving our cardiac output and rectifying that hypoperfusion. So as you can see here, there's a nice fun diagram. Dopamine binds to the beta-1 receptor. This leads to adenosine cyclase, converting ATP to cyclic AMP, and this activates protein kinase A. And basically, this leads to an opening of the calcium channels for more calcium to flood in. And there's a little like house inside our cell called the sarcoplasmic reticulum, which has all of our calcium in it, or a large portion of it, and this gets released, and this subsequently binds to troponin, which leads to the muscle contraction, right? So the higher rise of calcium, calcium leads to a stronger contraction, which will overall improve this patient's status, because we know 40 to 50% of patients' left ventricle in cardiogenic shock is compromised and damaged, and obviously they can no longer function as a pump, so now they need assistance in doing so, and this is why we can help and they can benefit from dopamine because of this process. And if you kind of examine the renal effects of dopamine, depending on the dose, this activates D1 and D2 receptors, which are present in the kidney. And kidneys are obviously a paramount organ. They have so many important processes, and if they're impaired and compromised, that can lead to a high risk of morbidity and mortality. So when these are stimulated by dopamine, it leads to renal vasodilation, because we want to improve our blood flow to the kidneys. And overall, this can lead to natriuresis, which is an excrement in sodium in urine, as well leads to diuresis, which is an increased amount of urine made. So that's just depending on the dose. So we look at the different dosages here. Dopamine dosages of less than 2.5 micrograms per kilogram per minute exerts its physiological effects on all these different areas. So it causes renal vasodilation, it causes vasodilation in our brain, as well as our coronary arteries, etc., and as well as our splenic vessels, which is involved in our hepatic vessels here, splenic vessels here, mesenteric, all this, and this obviously perfuses all these vital organs such as our liver, our stomach, our spleen, intestines, etc. So blood flow is compromised to those areas. That can lead to ischemia, eventually necrosis, and overall impairs these pretty vital organs. So that's what those doses do. But then you go into 3 to 5 micrograms per kilogram per minute, and this leads to increase in chronotropy and inotropy, so increased contractility and heart rate. It's important to note that depending on the resource, these can stipulate different effects by the different dosages, and as well there is an individual variability. Some patients can respond differently to different kind of dosages of it, and obviously there could be some crossover. So not at a 5 micrograms per kilogram a minute, it stops some physiological effects while others start over. There is kind of a blend of it, and again, it all depends on the dose and the individual variability. But if we look between 5 to 10 micrograms per kilogram per minute, this leads to increase in chronotropy and inotropy, but subsequently leads to this vasoconstriction. So where the pro-tachyarrhythmic events can happen is that it starts to happen greater than 10 micrograms per kilogram per minute. But overall, we want to achieve and administer the least amount of dopamine or any vasopressor to achieve a normal blood pressure. So we don't want to technically achieve a blood pressure like 120 over 80, 130 over 90. This is why our medical directives actually stipulate titrate dopamine to when you get a systolic blood pressure at least 90 to 110, because this will mitigate its adverse events, because dopamine can be proarrhythmic. However, we want to mitigate it, but we want to ensure we're perfusing and rectifying this hypoperfusion state, right? So this is why we try to titrate at least to a mean arterial pressure of 65, because that means we're actually perfusing our vital organs. So this is why that blood pressure stipulate 90 to 110. And if you're going to do so electively, we do it gradually over 5 to 10 minutes, because it can lead to rebound hypotension and adverse events if we turn it off too quickly. So that's important as well, right? But 10 to 20 micrograms per kilogram per minute, that's mainly vasoconstriction from the alpha-1 receptors shunting this blood to the core, etc., right? So again, we want to get the least amount of dopamine or vasopressor to achieve at least a MAP of 65 or systolic blood pressure of 90 to 110. That's why we want to do it. But again, we've kind of alluded to some of the adverse events. Obviously, if dopamine becomes or goes interstitial, this thing can lead to tissue necrosis. So you can appreciate the kind of reluctance to give dopamine in the pre-hospital setting. There is some good research suggesting that paramedics are uncomfortable, because truthfully, how often do we go over this? How often do you use it? How often do you review it? What about extrication? What about if we're worried during extrication, we're administering it and it becomes dislodged and goes interstitial and can lead to necrosis, etc.? So you can appreciate all this. So this is partially why we're reviewing it. Unfortunately, if it does go interstitial, stop the drip, obviously, and try to withdraw some of the fluid from the actual site, and then remove the catheter as well. And they can give and administer a medication called pentylamine in the hospital that helps kind of minimize the damage. So that's why it's good to patch ahead, so they can kind of get that prepared. And again, we've talked about it, dopamine can be pro-tachyarrhythmic, so especially over 10 micrograms per kilogram per minute. And that's why it's all in context to the circumstance. Because 80 to 90% of patients experiencing cardiogenic shock will be administered a vasopressor, and this is usually in the hospital setting. There's kind of limited research about dopamine in the pre-hospital setting for cardiogenic shock, but it's all in the clinical circumstances, right? Because if a blood pressure on a patient's 88 on 60, but they have good color, they're good altered, or they're not altered at all. It's like, does this patient actually warrant dopamine? Because the first line treatment for cardiogenic shock with hypotension is fluid therapy unless they're truly contraindicated, right? Because they have pulmonary congestion or pulmonary crackles. And it's a good reminder to note that patients are only contraindicated from fluid therapy or fluid bolus when they have pulmonary crackles that are cardiogenic in nature. So if a patient has a clear chest and they have peripheral edema, you can still give them fluid therapy, but we just want to always be careful, right? Because some cardiogenic shock patients will respond to fluid therapy, others won't. And that's all dependent on their comorbidities, their age, the size of the infarct, if it's causing the cardiogenic shock, etc. So some patients are fluid responsive while others are not. But we also give 10 mils per kilogram per minute for these cardiogenic shock patients because obviously we don't want to overflood the heart because at least 40 to 50% of their left ventricle is compromised. And if we increase the amount of workload by increasing this preload to it, that could compromise their already kind of impaired myocardium, and we don't want to exacerbate the underlying process. And as well too, obviously if you increase the heart rate, if you increase contractility, if you're increasing the amount of blood going back to heart by vasoconstriction, you're going to increase myocardial oxygen consumption. And this is already compromised. The heart is working so hard and so damaged because of this 40 to 50% impairment of their left ventricle. And it's trying to compensate with the endogenous catecholamines or insulin. So we do increase myocardial oxygen consumption, which can exacerbate the infarct if that's what's causing the actual cardiogenic shock. So you can appreciate this. But again, this is why we would try to titrate the least amount of vasopressor to achieve at least a blood pressure that's high enough to perfuse their vital organs. Then we stop and wean it off slowly. So those adverse events are recognized and known. But again, it's all depending on the clinical circumstance, right? Because again, if you have somebody that has a blood pressure of 70 on 40, they're cool, pale, diaphoretic, they're mottled and cyanotic, they are confused because they have lack of perfusion going in the brain, it's like, and they haven't responded to fluid therapy, okay, this patient could benefit from dopamine, essentially, right? So you imagine if you have a high infarct here and all this is subsequently destroyed, and we give dopamine to increase contractility, heart rate, etc., even though we're trying to increase the cardiac output and the patient's blood pressure, this can lead to a rise in myocardial oxygen consumption, which could exacerbate damage. But we also have to think, what's the alternative? Cardiogenic shock has the highest mortality out of all the shock states. Around 43% of patients in cardiogenic shock will have a mortality in the hospital. And that's comparison to septic shock, that's around like 37%, or so, all depending on the resource. But again, like cardiogenic shock has a high mortality. So this is why we have to be diligent and treat it effectively and promptly. So obviously we've been talking in this whole video that cardiac output is dictated by the heart rate and the stroke volume. So cardiac output represents the amount of blood going around our body over a minute. Usually that correlates to about 4 to 5 liters of blood per minute. And anything that compromises the heart rate or the stroke volume can diminish or rise our cardiac output. So in this circumstance, cardiac output is lowered because they have impairment in their stroke volume. And depending on the type of infarct or the patient's medication, maybe their heart rate's lowered as well, which could detrimentally affect the patient's cardiac output. So this chart just kind of summarizes the different effects that can happen depending on the dose. Because we start at 5 micrograms per kilogram per minute, and that obviously increases our cardiac output from rising our heart rate from the increased beta-1 effects. At 5 to 10 micrograms per kilogram per minute, we increase the cardiac output from increase in heart rate. And as well, this is where vasoconstriction happens. So it leads to an increase in systemic vascular resistance, which is our afterload. So it shunts blood to the core. It's like the toothpaste ball, you're squeezing it, or you're squeezing the blood vessels to pump blood somewhere to perfuse the vital organs. And specifically after 10 micrograms per kilogram per minute, this is just causes this vasoconstrictive effects. So if you look at the kind of the dosages between 0 and 5 micrograms per kilogram per minute, that's the kind of lower doses. 5 to 15 micrograms per kilogram per minute, that's their intermediate dosages, and after 15, that's the more higher doses. That's all depending on the resource, but again, we want to titrate the dopamine to achieve the least amount of blood pressure that can perfuse our vital organs while mitigating the adverse events. So we already kind of spoke about this. So it's all, the blood pressure is all in context to the clinical circumstance, right? So again, if the patient's blood pressure is 88 on 60, but they're got decent color, they don't have pulmonary congestion, they're not altered at all, indicating that they have good perfusion to their brain, etc. It's like, just because their blood pressure is less than 90, do we really want to give, or does this patient going to benefit from dopamine if they already are having a good perfusion status? So you can have that ability as a clinician that is supported by withholding dopamine until they're actually demonstrating signs of hypoperfusion, such as pale, cool, diaphoretic, they're mild, they are hypotensive with it, they have respiratory distress from pulmonary congestion, they're tachypneic, they're altered, right? So it's all in context. So just because a blood pressure is low doesn't mean they're not perfusing effectively. So it's all in context, right? But again, the first line treatment is fluid therapy, and if they are unresponsive to that, then we can move on to a vasopressor if it's indicated. So this is kind of analogous to having a low blood pressure in trauma, right? Like, does it make us feel better if we're giving a bunch of fluid to these trauma patients, even though they may still be perfusing their vital organs with a proper mean arterial pressure? But if we dump a whole bunch of fluid in them, then we can disrupt their clotting factors and exacerbate underlying damage, etc. This is kind of akin to dopamine, right? Because even though it can be beneficial in cardiogenic shock and other circumstances, unless the patient is truly manifesting with signs of hypoperfusion and a low blood pressure and they respond to other therapies, then maybe we should hold off on it. And that goes with all vasopressors as well. Then if you look at the route, so under our medical directives, we can only give dopamine by the IV route. And the great benefit of it, it works fairly quickly, within 5 minutes, and it only lasts less than 10 minutes. So the duration of it's quite quick. So that's the benefit to it. But everyone asks us, like, can dopamine be administered by the IO route? Because what if you do a cardiac arrest, you can't get an IV, you administer an IO, and you get a ROSC, and they're hypotensive and they need dopamine? Technically, any drug that can be administered by the IV route can go by the IO route as well. However, the problem is that it's recommended to have a separate designated IV line for dopamine. And because sometimes with an IO, you need a pressure infuser. And dopamine is recommended to utilize the Burtrol or the rate controller, so it's accurate. And we actually know how much medication we're administering, so that's why it's recommended to do it. And obviously, you can't attach a pressure infuser to the Burtrol, the rate controller. So that's kind of a key difference there in the nuance to it, right? And if you compare to other vasopressor rates, because other vasopressors are epinephrine and norepinephrine, and quite interestingly, obviously dopamine is a precursor to norepinephrine and epinephrine. They're all considered catecholamines. Dopamine is made in the brain and also made in the adrenal glands as well too. But if everyone asks, like, okay, why don't we have norepinephrine? Because if you look, the New England Journal of Medicine did a study and they compared it for cardiogenic shock, and norepinephrine was superior in the in-hospital setting. It had a less chance of mortality among patients, and it had a reduced chance of adverse events such as tachyarrhythmias in comparison to dopamine. But if you look at a lot of meta-analyses and systematic reviews, a lot of the vasopressors are about equal improving cardiac output, and all of them have side effects. But it's all in context to the situation, right? Because epinephrine is 100 times more potent than dopamine. And obviously, the epi and dopamine increase heart rate, inotropy, and cause vasoconstriction. But if you have a drug that's 100 times more potent than dopamine, that can exert physiological effects, but it all as well as has high risk of adverse events, right? So that's why we're also proposing, like, we don't patch for push dose epi at this time, because one, we're not trained on it, and the literature of it, even in physicians, there's high risk of med air. So if we haven't been trained on it, it's high risk for med air. Even among physicians that receive training on it, you can't take away once it's given. It's 100 times more potent than dopamine. That can obviously lead to adverse events, and you should have designated like central lines for epinephrine. It needs to be monitored appropriately, like by pumps, etc., right? And this also relates to norepinephrine. It's recommended to have a central line for norepinephrine. It's recommended to have proper training on it and get pumps, and we don't have that ability in the pre-hospital setting in Ontario at this point in time. And that kind of goes over the overarching theme that dopamine is beneficial for what we give it for in the pre-hospital setting, because we can titrate to specific dosages. It only lasts for about 10 minutes. And again, we just want to achieve the least amount of blood pressure that perfuses their vital organs. And if you look, norepinephrine has very potent vasoconstrictor properties. It can lead to increase in heart rate and contractility as well. But basically, Epinephrine and norepinephrine reserved for the in-hospital setting for patients that usually have a central line, because you have to monitor it because it can lead to necrosis too if the lines become interstitial. And it's good to have pumps and a variety of other different reasons. And the last piece we want to review is, how does fluid therapy actually render an effect? And that's because of the Frank-Starling law. So basically, the greater the stretch, the stronger of the contraction to a certain point. So if we get 10 mils per kilogram per minute to this patient, this leads to increase in preload to the right side of the heart. This leads to the baroreceptors responding by a greater the stretch. That leads to a stronger contraction, but hopefully improves our cardiac output as well, right? However, we know normal saline is an isotonic fluid, so only 20 to 30% of it actually stays in the vascular space because it gets equalized in the other compartments. So that's why you can see high dosages or high amounts of fluid therapy can lead to tissue edema and exacerbate further complications, etc. So that's why. But overall, the overarching theme was just to review dopamine's mechanism of actions, its risks, its benefits, how do you actually apply clinical circumstances to it. Normal saline or fluid bolus is the first line treatment, but some patients may be unresponsive to it or contraindicated to it. Then dopamine can provide beneficial effects. We could titrate it to specific effects depending on the dose, and it can be an important drug, and we want to mitigate its adverse events.